Hello, and welcome to today's training, Balancing the Hopes and Risks of Ketamine Treatment for Major Depressive Episodes with Gerard Sanacora, MD, PhD. I am Mary Geis, Director of Programs at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the chat pane of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. It is now my honor to introduce to you Gerard Sanacora, MD, PhD. Dr. Sanacora is currently a professor of psychiatry and the director of the Yale Depression Research Program. His work is concentrated largely on elucidating the pathophysiological mechanisms associated with mood and other neuropsychiatric disorders. Much of his recent research has focused on identifying the contributions of the amino acid neurotransmitter systems to the neurobiology of mood disorders and the mechanism of antidepressant action. In addition, he is involved in several early-phase clinical trials designed to test the clinical efficacy of newly developed therapeutic agents. Now there will be a brief pause while I pass the screen over to our expert. All right, Dr. Sanacora, you can take it away. It looks as if you have muted yourself. If you could take yourself off mute, that would be great. All right, we see your screen and just need to be able to hear you. There we go. Are you there?
Am I off mute now?
Oh, you are off mute. Thank you very much.
Okay, thank you. Thank you very much, Mary. Sorry about that. I do also apologize that just today they decided to start doing some construction on my building. So if there's a little background noise, I apologize for that. Well, thank you for attending. What I'd like to talk to everybody a little bit today about is balancing the hopes and risk of ketamine treatment for major depressive episodes. It's kind of a unique situation that we are currently finding ourselves in. Whoops, Mary, how am I progressing my slides? It is not. There we go. I'd like to start with just by sharing disclosures. I do consult to many different pharmaceutical companies, mainly in the development of novel therapeutic agents. I actually do research with several different companies, and I have shares and vested interest in a biopharmaceutical company that is interested in the development of novel therapeutic agents. Just to cover a brief background, what I'm hoping to cover is to share and discuss the real unmet need for new antidepressant treatments. Then to talk a little bit about the data that does exist mainly, and at this point we'll stick mainly to ketamine as an antidepressant agent. I want to highlight that ketamine is not a US FDA approved or indicated treatment for any mood disorders at this point. It is carries an FDA indication as a treatment as an anesthetic, and it has since 1970, but not for any mood disorders. And I'd like to review the data that does exist in a critical fashion, and then to move on to discuss what are the limitations of our knowledge and what do we really need to bring this treatment forward to clinic. So let me just start with the big question: is there really a need for new antidepressants? We have well over 25 FDA-indicated antidepressants. Do we really need more? And I'm sure you're all very familiar with the fact that the World Health Organization has recently designated depression as the leading cause of disability worldwide, and is considered a major contributor to the overall global burden of disease. I'm sure many of you are also aware that suicide has remained, suicide not always related to mood disorders, but the large majority being related to mood disorders, has remained the 10th leading cause of suicide for many years in the US, with over 42,000 deaths in 2014. And what is even a little bit more concerning is the recent trend over the past 7 or 8 years showing an increase in suicide rates, both total but also for males and females independently. The other major factor that contribute when thinking about the need for new antidepressant treatments is looking at the effectiveness of our current treatments. So I'm sure many of you are familiar with the results of the STAR-D trial. And this is really a question of whether you look at things as a glass half empty or half full. But if you look at these studies, if you look at remission rates specifically, you see that there's about a 37%, a little bit more than a third of the people that will respond and actually go into a full remission or have a full remission with the first antidepressant treatment, in this case, the SSRI citalopram. And the good news, I guess, is if you don't respond to the first one, you have about a 1/3 chance of having a remission to the second treatment. It doesn't seem to matter all that much which one you're switched to, at least in the STAR-D trial. But then it becomes a little bit more discouraging. So patients that didn't respond to either the first or second level of treatment, their chances of having a remission in the third level drops to less than 15, as it does to the fourth level. So this is really pretty good evidence that using our current armamentarium of antidepressant treatments, if you don't respond to the first two, the chance of having, or you don't have a remission in the first two, the chance of having a remission to that third or fourth level drops significantly. And then a little bit more discouraging even is the fact if you look at relapse rates in 1 year in this study, even those that responded to the first treatment had a 40% relapse rate within 1 year, and it only grows from there. Beyond that, if you just look at the people that ultimately did go on to have a response, meaning a 50% improvement, you see that it took, on average, 6 weeks for people to obtain that level of response. So even for the people that do go on to have a good response, meaning a 50% response, it took them 6 weeks to get there. So hopefully that is some increasing evidence to suggest that we really do need improved antidepressant treatments, at least for a substantial subgroup of patients with the disorder, but also treatments that could act more rapidly to alleviate some of the pain and suffering. The big question is, how do we go about identifying new targets of interest? People have been trying to do this for many, many years, and for the most part, we've been limited to the monoaminergic drugs, which really were first identified over 60 years ago. So how do we actually go about trying to identify new drugs? And one of the major new tacks that has been taken is to try to understand the pathophysiologic mechanisms underlying these disorders, to understand the pathophysiology and pathogenesis of these disorders at the molecular level. And there's been a lot of exciting new breakthroughs from the basic neuroscience fields that have suggested that several different pathways could be involved. And here I just outlined several of these, including the inflammatory pathways, and great interest in targeting neuroinflammation in treating these disorders. There's been several studies suggesting that neuroplasticity and the neurotrophic pathway could play critical roles in both the pathogenesis, pathophysiology, and also in the treatment of these disorders. Obviously, we know quite a bit about how stress plays a role. Well, actually, we don't know too much about how stress plays a role in causing these changes, but we do know that stress is a major contributor to the onset and precipitating many mood disorder episodes. So more recently, what we've grown to understand is how the amino acid neurotransmitter systems, specifically GABA, and what I will really focus on in this talk, how the glutamatergic neurotransmitter system and how disruptions of these systems can significantly contribute to the pathophysiology of mood disorders. This is just a review from this is a paper that we had a few years ago, trying to understand how stress alters the glutamatergic neurotransmitter system. And I don't expect anybody to really be an expert at this level. But really the point is to show that we have now good evidence that high levels of acute stress and, more importantly, chronic stress can dramatically alter the function of the glutamatergic neurotransmitter system, altering both the release of glutamate in the synapses, especially in regions like the prefrontal cortex and the hippocampus, but also altering how the glutamate receptors are modulating the effects of glutamate. And lastly, some very interesting information and very a different way of thinking about things is some of this evidence suggesting that stress can have large effects on glial cell function and thereby impairing the clearance of glutamate from the synapse. We believe that these effects, specifically on the glutamatergic system, can underlie and contribute to some of the important factors related to mood disorders. With that in mind, there's been great interest in targeting several different components of the glutamatergic neurotransmitter system in developing either novel treatments for mood disorder or preventative mechanisms in addressing mood disorder. So what I'm going to focus on for the rest of this talk is specifically the NMDA glutamate receptor. So these are the NMDA is a subtype of the ionotropic glutamate receptors. And I don't think, for the purposes of this talk, I don't think we need to go much more into the basic pharmacology with just explaining that based on some of the early studies suggesting that there was abnormalities in the glutamatergic system of patients suffering from mood disorders, and rodent models showing that with chronic stress we can dramatically alter the glutamatergic neurotransmitter system, there's been interest in targeting these pathways, and specifically going back now over 20 years, there's been real interest in seeing if we could use drugs that modify the NMDA ionotropic glutamate receptor to target depression. And at this point, probably many of you have already seen at least the study on the left or the study on the right, but these were the first studies using ketamine. So ketamine is an anesthetic agent. It's been, as I mentioned, FDA indicated for the treatment of depression since 1970. And it binds to the NMDA receptor, and it actually is what's called an open channel blocker. So when that ion channel becomes open, ketamine can actually insert itself in there and block the function of the ion channel with continued stimulation through glutamate. So it acts to block the NMDA receptor channel. And the original study was done here at Yale by some of my colleagues, Rob Berman, Dennis Charney, John Crystal, and others, was to simply see if you gave a single dose of ketamine at a sub-anesthetic range, which is 0.5 milligrams per kilogram given IV over 40 minutes, which is enough to have a very clear effect on cognition and perception, but not having an anesthetic effect, to see if that would alter depressive mood. And the way this study was done was 1 week a patient would come in and receive a placebo, which was saline in this study. Another week it would come in and receive ketamine at the 0.5 mg per kg. And these were counterbalanced, so different of the patients. And remember, there's only 8 patients in this study. But 1 week, some of the patients would get the placebo first, and others would get the active drug. But you can see very clearly that the week getting the placebo, the blue line, the light blue line, there was really no impact on their mood at all. Really astonishingly, and really a surprise to everybody, I think, was the fact that within 4 hours after receiving ketamine, and I'm sorry this is not projecting so well, but this is the Hamilton Depression Rating Scale on the left, there were dramatic increases in the Hamilton score with decreases in depression severity, showing up as early as 4 hours, but by 24 hours, 48 hours, and by 72 hours, having a very pronounced effect. Gradually, these scores did go back up. But at that point, I think everybody was extremely interested, but that there was clearly some confusion trying to figure out what was going on. So if you can see, the next study to really come out, to be published, was in 2006 out of the National Institute of Mental Health by Carlos Zarate and others, where they basically replicated that finding with a little bit larger sample now with 18 people, but you can see within 1 day, 71% of the patients actually reported a response, meaning at least a 50% improvement in their depressive symptoms 1 day after receiving that subanesthetic dose of ketamine. And in fact, 1/3 of those patients actually reported having an improvement in their symptoms to the level that it would meet remission criteria at that time. And you can see if you follow it over the next few days that there is a decrease in the improvement. So people get much, much better, and then over the next few days, there was some decrease in that improvement. But if you compare it to the placebo, which is the light blue, you can see that there's a dramatic decrease, where the placebo group shows almost no response at all. So based on those two studies, it stimulated quite a bit of interest, and this has now been replicated multiple times. And in fact, this is a paper that's now about 2 years old, from Newport and others at the APA task force, showing that if you just look at day 1 in these studies, there's the odds ratio of having a response to ketamine is about 10-1. Now that's dramatically higher than we see with any other antidepressant, even at 6 weeks. If you look 1 week out, and again, it's important to remember, the ketamine here is only given once. It's given once in an IV infusion lasting 40 minutes. Ketamine has a relatively short half-life, so it's cleared from the body very quickly. At least the parent compound and the major metabolite is cleared very quickly. So we're seeing these effects lasting at least out to a week, where people's mood continues to be improved despite the fact that the drug has been metabolized. These findings have now led to a widespread interest, especially the lay media has picked up a real interest in this, and just in the past week, there's been several reports on the effectiveness of this drug, and I think it speaks to a few things. I think it speaks to, one, the real desperation in the field that we really do need more effective, more rapidly active treatments. But two is, I think there is some element of the media liking, the good boy does good studies, so that with headlines like Special K effectively treats severe depression. But I really think there's two sides to that story. There's also been real interest in patients in getting the treatment, and in people and clinicians willing to provide the treatment. So this is the result of a recent survey that we've sent out to 81 sites that we were able to identify, both academic and community-based clinicians who were providing the treatment. We were able to get 54 respondents, which is actually a pretty good response rate for clinician surveys. And you can see from this graph the rate at which clinicians that are providing ketamine treatment is growing over the past few years. So there really is a growing unmet need for these medications, and there is a growing number of people willing to provide the treatment. What becomes so difficult is, how do we actually balance the potential benefits of this treatment with the really limited amount of knowledge that we have to date? And that's what I'd like to talk a little bit about for the remainder of this time, just to present a little bit of a critical overview of what we do know about the treatment, and then to go into a little bit of the details about how we best can move this treatment forward. So when I review this data, I see several major issues that remain to be answered or remain to be clarified. These are what I say are the factors that most limit the use of ketamine in clinical studies. The first one just simply being are these effects of ketamine really non-specific? Is it really just due to unblinding? When you give ketamine to somebody, especially at 0.5 milligrams per kilogram, the patient usually will know they got it, and the clinician will usually know they gave the active treatment, especially when it's compared to saline. So we really have to answer that question. Is this really non-specific effects, or is there something truly unique to ketamine? The other big issues are we really haven't worked out the optimal dosing in any way. We don't know the actual optimal dose. We don't know the best route. We don't know the frequency to deliver it. There's also very little known about the duration of the effect. In fact, everything I showed you to this point has all been a single study and really not looking any further out than 1 week. So that's extremely interesting in terms of novel drug development and getting the field excited. But it really doesn't convince me too much that this is a very valuable clinical tool. But I'd like to present some of the newer data that's coming out that is starting to sway me more. And this is really specifically related to the longer-term effectiveness. Where we really have a true dearth of information is knowing much about the longer-term safety of the treatment. And lastly, we know very little about the moderators of the response, specifically what subtypes of mood disorders or other psychiatric disorders. Are there any genetic predictors, or are there any phenotypic differences that may help us predict who's more likely to respond well or to have a negative response? We also know very little about the potential drug-drug interactions regarding safety at one level, but more importantly, regarding efficiency or efficacy of the treatment. And then lastly, it's the idea of what is the actual mechanism of action? How does this drug work? We're starting to learn a lot about from preclinical studies, but it is critical in understanding the mechanism so we may be able to develop other treatments that may not have the same unwanted effects, such as abuse liability or effects on the physiology or a psychological function that we acutely see with ketamine that we would rather not have. All right. So here, the question is, are ketamine's antidepressant effects largely due to functional unblinding? So one of the arguments for this is, if you look at all of these, and I just have 4 studies up here, Berman's study, another Valentine study here from Yale, Ms. Roddy's study from the NIMH, or the Lapis study out of Mount Sinai. The real interesting thing here is if you look at the placebo response rates, it's very low. Now, there are some arguments why this may be the case. One is almost all of these patients were treatment resistant with a severe level of depression. The other fact is that this really only goes over a week or even 3 days, so we may not see that placebo type response, but it's very different than what we see in most other studies in depression. We usually have some placebo response rate. So people have argued here, well, placebo doesn't work very well when people know they're getting placebo. And in fact, I would argue that probably is the case for many of the patients here. When you're getting ketamine, you know you got it. When you got saline, you know you didn't get ketamine. So that is one of the arguments that really needs to be addressed. I think to date, the best study that has tried to address this is studies by Dr. Morrow at Mount Sinai and Dr. Matthew at UT Southwest, where they used midazolam, Versed, as the control. As the placebo control. And here what you can see is now there is a little bit more of a placebo response, more than the flat line that we were seeing with saline, but still the ketamine showed a highly statistically significant improvement above the midazolam effect, both acutely but also being maintained for the week. So there does seem to be a true effect of ketamine above and beyond just the non-specific effect that they're getting through the functional unblinding. So I think to date, this is the best evidence. There's some more evidence that will be coming out shortly with a dose finding study that I think will also support this contention. But there are still some problems with this. One, patients were still able to, on average, be better than random in guessing whether they were getting the actual placebo or not. And so there may still be some level of functional unblinding that compromises these results. The next 3, I think we can address all at the same time. And these are really the limitations regarding how do we use this medicine and is it safe to continue to use this for long periods of time. So starting with at what dose should ketamine be delivered for the treatment of depression. So it's really unique that this study, not this study, this whole line of research really came out of the academic environment. This was not studies that were initiated through pharmaceutical industry. And through academia, when this was originally studied, the interest became much more on trying to figure out the mechanism of action. So everybody has been working on how does the drug work. Very, very little effort has been put into figuring out how to optimize the clinical effect to this point. And if you look at some of the mechanism and some of the studies, the preclinical studies, there's reason to suggest that there may, in fact, be a very important dose response curve, and it may be a relatively narrow therapeutic window. So these are some rodent studies that were done. The top level panel is work from Ron Duman, one of my colleagues here at Yale, looking at the forced swim test. This is a very classical rodent model of antidepressant action for drugs. So this is looking at the swimming in the forced swim test, or the immobility, looking at 24 hours after giving a dose of ketamine. So ketamine is given on one day, and then 24 hours, we look for any evidence of an antidepressant-like effect. And here, the 10 milligram per kilogram dose, which is a sub-anesthetic dose in rodents, produces a nice antidepressant response, meaning there's much less immobility. The animals continue to swim, as opposed to really giving up and showing despair and just floating. But the interesting thing is increasing the dose to 80 milligrams per kilogram, which is right on the cusp of being anesthetic, where the animals are now, when you acutely give it to them, are moving very little. We really see no antidepressant response 24 hours later, when the acute effects of the drug have completely worn off. So we see that we lose that effect. That is the top left panel. The top right panel is actually looking at some of the cellular changes that occur within the hours after receiving ketamine at various doses. And interestingly, you can see that there seems to be a dose-response curve where there's increasing levels of phosphorylation on some of these critical proteins involved in cell plasticity, specifically involved in the mTORC pathway. But you can see 1 milligram really not having much of effect, 5 increasing it, 10 milligrams per kilogram. Now remember, this is rodents, not humans, so there's going to be big differences in what the doses are. Having increasing effects, but again, going to that higher dose range that's in that anesthetic dose range, we no longer see these changes within the hours or even 24 hours after getting that dose, suggesting that it's what we call an inverted U-shaped curve, that there is an optimal dose where we may get the highest benefit, but being too low or too high, you can lose that effect. On the bottom panel is some work from my lab looking at measures of glutamate cycling and GABA cycling. So actually looking at activation of the medial prefrontal cortex in the brain. And again, a very nice dose response curve showing increases from 1 mg to 3 mg to 10 mg to 30 mg, which are all sub-anesthetic doses, but then simply going from 30 mg to 80 mg, losing this effect. And then if we, again, replicate that forced swim test, we see the same type response, that really it's this intermediate dose, still in the sub-anesthetic range, that really generates the biggest antidepressant-like effect in the rodents. So it's very interesting that it may be a real dose response curve that exists with this medicine. And we may have just been very lucky that that original study by Berman, they chose the 0.5 mg per kg, or it may have never been noticed. There is, and we should very, very soon, in fact, at the ASCP meeting coming up in a few months, we've just completed a study along with MGH, Baylor, Mount Sinai, Stanford, and Texas, looking at a dose response curve in humans. And that data should be available very soon. As I said, in about 2 months, that'll be made public. All right. The next is, can ketamine induce antidepressant effects be sustained or improved? So again, every piece of data I've shown you to this point has been a single infusion. So just one infusion and then looking out for a week, which I said is, from a scientific perspective, is incredibly interesting, but from a clinical perspective really doesn't mean that much, at least to me as a clinician. So there were some early studies to suggest in terms of case series that repeating the dose of ketamine may be effective. But this is really the first randomized placebo-controlled trial that tried to look at the effect of repeated dosing. And this study was interesting because it was really aimed at trying to understand how frequently ketamine should be dosed in patients for the treatment of depression. So the way this study worked is there were a total of 68 patients, and they were randomized into two groups to begin with. One either to receive treatment 2 times a week, or the other to receive treatment 3 times a week. And then within those groups, they were randomized to either receive the placebo, saline, or ketamine at 0.5 mg per kg, that standard dose. So what do we see the results of that study? So this is a study funded by Janssen with several academic groups participating in it. What we actually see is a very nice response. So if you look at the green circles, we see on the left panel, twice a week dosing, we see a very nice effect of the ketamine treatment, dropping down over the first 3 and then seeming to plateau out over the 2-week period. And we can see that the 3 times a week, there was no clear numerical difference in the score. So this led us to conclude that there was no evidence to suggest more frequent dosing than twice a week, but also gave us really the first evidence in a placebo-controlled trial that you can actually continue to improve the response with repeated treatments and actually maintain that response at least for 2 weeks. And you can see the responder and remitter rates in this study up top. And if you look in clinical practice, so again, we surveyed as many of the providers around North America that we could find who were using ketamine. This seems to be a pattern that most people are falling into. So when these clinicians are initiating ketamine treatment, it seems that the majority of them, and you can just see this is the frequency that the frequency by the frequency of the number of people using, and then each one the frequency of delivering on the y-axis. So you see the majority of people are dosing either 2 or 3 times a week to initiate treatment. And that seems to be the pattern that people are falling into. The next response is asking people approximately what % of their patients that they treated achieved some meaningful response. Now this is something we all have to take with a grain of salt, because we have no way of verifying these responses, and we've had no prospective measures to verify this. But at least the clinicians around the country, again, reporting greater than a 50% response in their practices. Now, again, we have to take that really with a grain of salt, but I think we can learn from this. We can learn a lot from clinical practice. If we do look at that first study I mentioned to you, the 2 versus 3 times a week study, that study, after going through those 2 weeks of blinded treatment, they were able to continue with unblinded treatment. And if you look at that, it looks like we were able to sustain the response in many of the patients until the end of the 1-month treatment. And then you can see that many still maintained a good response, but if you look at that follow-up period, some people then start to relapse at some point. So, and if we look again at the community sample, what they're telling us, for the patients that are treating with psychiatric disorders, and over 90% were either for unipolar depression or bipolar depression, we see that the pattern they fall into is that they do require some continued maintenance treatment. So this is important because, especially when we're talking to patients, for the majority of patients, this is not a curative treatment. It's not that you get a ketamine infusion, or not even get 4 ketamine infusions and then it's done and you're cured. It looks like the large majority of these patients are going to require some ongoing continuation ketamine treatments, which is going to be very important, especially when we start thinking about the safety implications. And when we ask these community providers about what frequency are people coming back for continuation treatment, you can see here that the most common is somewhere around once a month. And I know our own clinical experience here at Yale seems to match that very well, somewhere between once every 3 weeks or once every 5 weeks. The patients that do have a good response to ketamine report that they're starting to feel some loss of effect, and they are coming back for a booster. One of the treatments that we've been very interested in is seeing if we can combine other forms of therapy with ketamine to induce a more prolonged or sustained response. And one of my colleagues working here, Sam Wilkinson, has been very interested in using cognitive behavioral therapy. And there's really a twofold rationale for using this. The first is we know that cognitive behavioral therapy is very effective at decreasing relapse rates, or at least in extending remission rates. And we know ketamine seems to be very good at getting people better. So can we combine those two to have a rapid response that can be sustained? The second and more of the neurobiological basis to this is if we really believe that ketamine is inducing neuroplasticity, which I'll show some data later to support this, can we use this period of time when neuroplasticity is induced to actually try to change cognitive schemata, to actually have people develop different ways of thinking about things? And if you can look at the data from this, so the way this is, the shaded area, for 2 weeks, patients received ketamine twice a week, so a total of 4 ketamine infusions, while they received cognitive behavioral therapy twice a week. So basically, they got ketamine on Tuesday, CBT on Wednesday, ketamine on Thursday, CBT on Friday. And then they continued. And then the ketamine stopped, but they continued to have weekly CBT moving out. And really what you can see here is this red line are the people that really didn't show at least a 50% response to the ketamine. So these are, again, this is a small sample, and for some reason it's not projecting. There's only 16 people in this whole study. And we were lucky in the fact that 8 of the patients had a very good response and 8 of the patients did not have a good response. But of those patients that had a very good response, they maintained that response with the cognitive behavioral therapy over a period of 10 weeks. The people that did not have the response did not gain any further. In fact, it looked like they went right back to their baseline very shortly after getting the ketamine, despite having the weekly CBT. So we look at this as evidence that there may be some ability to use other forms of treatment, such as cognitive behavioral therapy, to prolong the duration of response. That being said, there was some concern that if we look out over the longer period of time, once the CBT was actually stopped, so once we got out to 10 weeks or 8, that extra 8 weeks of CBT, there was an increase in relapse rates despite having gone through CBT. So we don't really know if we continued CBT out longer, or if we get boosted sessions of CBT, whether we'd be able to extend that or not. And that's something we're very interested in looking at. The next area to examine is, can ketamine be effectively administered by other routes? So everything I've mentioned to this point has been IV, but ketamine can be administered intranasally or even orally. The bottom line for this is there's very little evidence, and the bioavailability of ketamine is quite tricky, especially when you start giving it either intranasally or especially orally. And as I've shown you, there may be a relatively narrow therapeutic window, so this may be a difficult route. There is some evidence to suggest that intranasal ketamine is effective. This is, again, is the study out of Mount Sinai. If you look at how clinicians are using it, the overwhelming majority of clinicians are using the intravenous route. There are some providing it oral or intranasally, but it is a relatively small percent of the population. There is a large effort underway from Janssen Pharmaceuticals to develop S-ketamine, the S enantiomer of ketamine, which has a higher affinity for the NMDA receptor than the R-ketamine enantiomer, and has been formulated in a way that actual reasonable doses can be given intranasally with some confidence in the bioavailability. And these studies have been completed, and the results have been presented, at least at the ASCP meeting, with very positive results showing that S-ketamine can be delivered intranasally with good effect. So we'll be hearing and seeing a lot more of those studies in the near future. The other big question clinically is it safe to dose ketamine repeatedly? So there have been literally millions of people that have been treated with ketamine since the 1960s. as I said, it's received an FDA indication since 1970 as an anesthetic agent. It's used throughout the world as an anesthetic agent, especially in pediatric anesthesia. So we know an awful lot about ketamine. But the large majority of those of that experience is with single dose. What about repeated dosing? So there's some concerns that we have about the safety of using ketamine. You know, obviously there is still the short-term risk. So what happens when we give ketamine acutely? So there are some real meaningful changes in cardiovascular function. There's increases in blood pressure. There's increases in heart rate that could be really meaningful. There is very little evidence that there's any serious respiratory depression, as is seen with other anesthetic agents, but always still a concern at any level. And then there's the acute psychological changes. So there's very good evidence to suggest that there are cognitive and perceptual changes. So if we just look at the physiologic changes, and these are just from a few studies you can read, but basically there's some evidence that occasionally patients will not be verbally responsive, although in every situation their respiratory status remains stable and their cardiovascular status remains stable at the 0.5 mg per kg dose. But there is pretty good evidence that there are changes in systolic blood pressure. For example, in this study, about a 20 millimeter mercury increase in systolic blood pressure and about a 14, 13 millimeter mercury increase in diastolic blood pressure associated with treatments. And a significant, about 1/3 of the patients actually showing increases in their systolic and diastolic blood pressure over 180 over 100. So this is some evidence to suggest that we at least need to be careful in who we're treating with this drug, and we take some level to monitor their cardiovascular and respiratory status during a treatment. And from the psychological aspect, it's been very clear. In fact, some of the work going back to the early 1990s has shown that ketamine has rather pronounced effects, especially at the 0.5 mg per kg dose, on perception, cognition, and anxiety. So we also have to be prepared to manage the acute psychological effects of the drug. And again, these are all pretty much contained within the first hour and definitely within the first 2 hours of the treatment administration. For the longer term treatment, there's some concern based on preclinical data to suggest that repeated dosing of ketamine, even in the sub-anesthetic dose range, could be having some cognitive effects and actually some structural effects in the brain. In humans, the data seems to suggest that high-level, high-frequency uses of high doses of ketamine, mainly through studies of ketamine abusers, show evidence that there is some effects on brain structure. And again, here looking at gray matter volumes in the brain and actually showing some atrophy in the frontal cortices. And also cognitive impairments with high-frequency ketamine abusers actually showing some impairments in working memory. Where uniquely the recreational users, those that use it on a more like a weekly basis rather than a daily basis, didn't seem to show those effects. But the point here is there is some evidence to suggest, at least in high-frequency users, that there is an association with some neurocognitive impairments and potentially even some structural impairments. Now, where is that level of safety? We don't really know. It doesn't seem to be very evident in ketamine abusers that are using it at a more moderate level, but where that level lies is still unclear. The good news I can say is, at least in the few studies that have looked at cognitive function in depressed patients receiving ketamine, now this is really only up to 2 weeks of receiving ketamine, so this is not long-term. The data from a study out of Minnesota, another study out of the UK, and a study here from Yale seem to suggest that there's really no good evidence that at least 2 weeks of ketamine treatment is causing any cognitive impairment. Now, obviously, that's not enough to really provide good safety data, but at least we're not seeing any big red flags suggesting that this could be a real danger in the short term. But we really need much more data on the longer term effects. Just to wrap up, we'll move a little bit into what are the moderators of the response. So in other words, what do we know about who is more likely to respond? Is there anything that helps in that sense? And I have to say there's very little data on that. I could talk a little bit about some genetic studies that we've done suggesting that the BDNF Val66 MET gene may help predict people with good response. But these are all pretty preliminary data, and I don't think they're really ready for use in clinical decision making at this time. I think the one area that may be related to clinical decision making could be in the area of suicidal ideation. So do patients with suicidal ideation have a specific response, or do suicide symptoms have a more rapid or a more robust response to ketamine than placebo? And this is just a large review that was recently done by our group, just covering all the studies looking at suicide symptoms with ketamine, and all a very consistent study, a very consistent finding in these studies suggesting that ketamine does produce a very rapid and robust anti-suicidal effect in these patients. Now, that being said, the majority of these studies, in fact, I think I can say almost all, but maybe one of these studies, excluded patients that had imminent suicide ideation. So, and patients that had higher levels or any intent to suicide. So these are difficult studies to interpret. But what we do see from this is it does seem to be that whatever suicidal ideation is being reported is responding robustly and rapidly to the treatment. The one study that was recently completed was a study sponsored by Janssen, actually using S-ketamine at 84 milligrams in imminently suicidal patients who were identified through presenting to an emergency room. And here you can see that the very rapid, robust antidepressant-like response over 2 days in these patients compared to the placebo control. Now, I have to highlight the placebo control here was on top of the best clinical practice that could be provided, basically outside of giving ECT or an MAOI. So patients were brought into the hospital, these were all admitted, they were offered the best clinical treatment that they could get, and then on top of that study, they were either randomized to receive S-ketamine or to placebo. And you can see very nice separation. And then on that bottom right, you could actually see the percent, the frequency, either people assessed not to require any intervention, or to require only outpatient, or to require continued inpatient. And you see a pretty marked shift in terms of the patients that were considered to have really minimal risk or risk only requiring outpatient intervention over a 2-day period. So this suggests there may be some hope of using this type of treatment to either abort hospitalizations or to reduce hospital length for patients. And lastly, what are the mechanisms of antidepressant action? So this would be another whole hour discussion, and I'd love to do that at some point, but I don't think this is the appropriate setting right now. I can say there's a huge amount of interest in trying to understand the mechanisms that contribute to the effect. Some of the most exciting work, I think, has come from several of my colleagues here at Yale, and work that we've done to suggest that the actual effect of ketamine is related to its increased or enhanced stimulation of neuroplasticity in several brain regions. So there's data that's actually quite remarkable. If you look at the colored figures down in the bottom right, showing that spine density, so actually the spines that are making these synaptic connections are increased dramatically within 24 hours of getting ketamine. And other studies by this group has shown that we see a pretty marked reduction in these spine densities with chronic levels of stress, and that's reversed very rapidly with the treatment of ketamine. And in terms of the actual mechanisms and the stimulation that's required to get those, there's a huge effort going on to try to understand the specific mechanisms that's mediating those. Based on that, idea, there are several novel agents that are in development besides ketamine, um, that are in various stages of either preclinical or clinical development, looking at the ability to use these other treatments to produce the antidepressant effects, and possibly, at least for some of these, that may be able to produce these effects without having those more acute effects on cognition and perception that may limit the real clinical utility of ketamine. So with that, I really just want to give an overview and to recap. This really is a unique situation where we have a drug that has been FDA indicated for over 45 years as an anesthetic, but now becoming very popular or increasing its use as an antidepressant without FDA indication, or without really a tremendous amount of data to back up its efficacy, or at least its long-term efficacy and its long-term safety. And a drug that we know carries some real baggage. I mean, we know that there's true abuse liability associated with it. We know that there are some very rapid effects on physiology that need to be monitored. And we have some concerns, at least, that chronic dosing of this drug may have some detrimental effects on the brain. So I think, you know, this comes to us as clinicians. How do we balance this? How do we balance what could be a very potentially important new treatment? And I can say, and I do say, I've had several patients where it truly has been truly life-saving, and they will say the same, and it has maintained the response. Now we have some patients going into their third year of treatment. So there are clearly cases where this could be tremendously clinically beneficial. But how do we balance that with the limited amount of information we have? And I think the best I can tell people is to gather as much information as possible, and to make sure that make sure that patients, when they enter into any of these treatments, understand the risk and benefits to the best of their capabilities. And the last part I really do, and so we recently had a consensus statement on this that was published in JAMA Psychiatry that I would encourage people to look at. And the last part I would really encourage people is, if you have patients that you are considering for ketamine treatment, please consider looking into a clinical trial. I mean, that's really how we're going to advance our knowledge in the field. We're really going to have controlled data on how effective and how safe this drug is in the longer term treatment, whether it be ketamine or S-ketamine or some of the other novel treatments that are being examined. All right, and finally, take-home messages. There's strong evidence at this point. I think I can say that with great confidence, that ketamine can produce rapid and robust antidepressant effects, at least in some people. And I think in the majority of these studies, we see that it's at around 50% or plus. I think there is now increasing evidence that repeated dosing can sustain the benefit, at least going out for a month or so. But there's still very little published data related to the longer-term efficacy and safety of repeated administration. There are many, many questions related to the appropriate dosing, patient selection, and how we manage potential moderators and mediators of effect. And then last, as I highlighted, there are now several drugs in development, and I think we're going to be hearing a lot more about these, but what really is critical to advancing this field is that there's participation from the clinician in the trenches, and in terms of getting real patients involved in these clinical trials, so we know what the real efficacy is and what the safety is of this treatment. Thank you. Just have a list of my collaborators and the funding that goes into supporting the research that was done here. Thank you very much.
All right, thank you. Yeah, we have so many questions that have come in, and I will we'll try and get through as many as possible. I apologize in advance if we don't get to them all. I'm going to throw two at you right away. One is it less glutamate that contributes to depression? And then the second one is, does the efficacy go down, and are multiple doses needed for injection versus IV administration?
So I'll start with the first one. You know, our data, and I think the majority of data in the field suggests that it's not, unfortunately, it's not as simple as less glutamate or more glutamate. The evidence seems to suggest that there's a disruption in the regulation of glutamate. So what our models propose is that, in fact, there's a decrease in the point-to-point transmission of glutamate, but there may be some increase in the volume transmission. So we think that there's some disruption in the regulation of this glutamate synapse. So it's not simply too much, too little. It's more a matter of there's probably more where it shouldn't be and less where it should be. And it's not being released in the controlled fashion that it should be. The second question, I wasn't 100% sure on the difference between you said between the infusion and the IV. Can you repeat that?
Sure. The question read, does the efficacy go down and are multiple doses needed for injection versus IV administration?
I'm not, injection and IV administration are, in my mind, the same thing, unless we're talking about IM injection, and there's incredibly there's no data on that I'm aware of, really. It looks like, at least the data that's shown with repeated dosing, the effect seems to be increased, at least over the first week or two, and then it does seem to reach plateau. But I'm not sure if we can clarify what they meant by the difference. Did they mean nasal insufflation, maybe? And with nasal insufflation, the data, we really haven't had any head-to-head data to look at differences between insufflation or IV injection.
Okay, we'll see if any clarification comes in. In the meantime, the trials you were talking about were open trials or double blind? The Hamilton was rated by a blind rater or the treating psychiatrist?
So I tried to be very clear. If I wasn't clear in saying which ones are open or which ones are double blind, I tried to limit these studies to double blind placebo-controlled studies for the most part. The ratings were done blinded for most of these studies, but I have to say, and I tried to make that point very clear, it's really hard to, there are problems with functional unblinding. Even if the clinicians are blinded, in terms of the raters doing it, the patients, for the most part, are pretty good at guessing whether they got the active treatment or not.
Okay, next question. I currently have a patient in private practice who uses ketamine to self-medicate, but does not look for or like the disassociated feeling. How do we differentiate between substance abuse and effective treatment?
Yeah, I mean, this is the age-old question in the field, not just related to ketamine, but any drug. The first thing that I would say and emphasize the fact that there is very little evidence that frequent dosing is beneficial. So I don't know how they're self-medicating. I do see a fair amount of people that are using ketamine on a regular basis, and the data that are available suggest that there is no real benefit to that. In fact, there's clinical trials that have been done looking at drugs that have a longer half-life, like memantine or even the CERT 301, don't seem to have nearly as much clinical efficacy as the ketamine when it's used, in a pulsatile fashion with weeks between treatment. So obviously that's not a definitive answer, but I think that there is very little data to support frequent daily use of the drug at this point.
Thank you. Another question, has anyone looked at how motivation, attitude, willingness, excuse me, i.e. psychological variables, affect the response to ketamine? I have a patient who has chronic depression, over-controlled coping style, aka Tom Lynch's work, and borderline features who has had multiple injection doses and loses effect after the first 24 hours. She is willful and always says that won't work to most interventions.
Yeah. So, and this is what I was saying, that there's very little data to look at the moderators of response, and this was one that would be considered a moderator. There isn't much. There's some work now trying to address patients' attitudes towards the treatment and response, but to this point, we have basically no data to support that, at least none that I'm aware of. And one of the other big questions related to the moderator is actually the use of benzodiazepines. The preclinical models suggest that you do need inhibition of at least some GABAergic synapses, and by giving these benzodiazepines, could you actually be attenuating or blocking the response to ketamine? But we don't have the data to really show that yet. But it's just one of these ideas that there's still a lot of questions, both from the psychological, but also from other moderators that could be having an effect.
Okay, and one final question as we come to the top of the hour. Does midazolam, I'm sorry, I'm going to say this wrong, Midazolam have an amnesiac effect? Does it have psychoactive effect? What is the subjective experience from midazolam? I apologize for.
That's okay. So midazolam or Versed is a benzodiazepine. It's a rapid-acting benzodiazepine that is unique, and it does have some amnestic effects, like all benzodiazepines do. At the doses that it was used in these studies, it's relatively low, and I don't think the amnestic effect is that dramatic. But for the most part, if you can guess what a benzodiazepine would do, that's what this dose of Versed would do. It does have some anxiolytic properties, so people do feel relaxed. They feel a little bit sedated. Their blood pressure will actually go down some. In fact, it's unique, and this becomes a real challenge when you start talking about getting the best placebo to use in these studies. Is this may be one case where the placebo actually carries greater medical risk than the active drug. So giving IV midazolam actually runs some risk of respiratory depression to a much higher extent than ketamine does. So this is a unique situation where we have to really justify using the placebo. I mean, we want to clarify. So if patients are truly naive to benzodiazepines and to ketamine, they may not be able to tell which one they got. And in fact, it's much better at blinding the treatment than using saline. But you have to balance that with the relative risk of using the placebo that may in fact be more dangerous than the study drug.
Okay, well, we are at the top of the hour. I just want to thank you so much for this really in-depth, informative presentation. So again, thank you, and thank you to all of our attendees for taking the time for being with us today. In about an hour, you'll receive an email that includes an evaluation of today's presentation, and we would very much appreciate if you would complete that and provide your comments to us. The email will also include a link to view the recording of the webinar, and we hope that you'll join us in just a couple of weeks at the ADAA conference in San Francisco, where you can learn more about this topic. So on behalf of ADAA and our presenter, thank you so much for joining us today, and have a great rest of your week.
Thank you.
Thank you.